take a few seconds.
Okay, thanks, Amanda.
Confirm live.
Good morning and welcome to this meeting of the Joint Health and Overview Scrutiny Committee. I'm Councillor Karen Calder, the Shropshire Co-Chair of the committee. I'm obliged to inform you that this meeting is being live streamed and recorded. Members of the public will be able to hear the audio of the meeting and view the papers shown on the screen. This meeting is being held using remote technology, and should any committee members experience technical difficulties during the meeting, they should immediately contact the designated IT officer on the number they have already been supplied with. Everyone is requested to mute their microphones unless asked to speak. Please only use the chat function to indicate the desire to speak. Do not use it for anything else. As Chair, I will interpret the Council's existing standing orders in the light of the requirements of remote participation, with advice from the Monitoring Officer to make a ruling. At the start of the committee, I will ask the members of the committee to confirm their presence and any disclosable pecuniary interest they have in any of the items on the agenda. I will ask everyone invited to speak during the meeting, including members of the committee and officers, to introduce themselves each time they speak. I will now do a roll call of members. If they have any disclosable pecuniary interest to be discussed, which is not included on the register of interest, please indicate at this point and leave the meeting prior to the matter being discussed. I myself have no interest to declare. David Beachy. Councillor Stephen Burrell. Ian Hume.
Here, Chair. Nothing to declare.
Thank you. Councillor Heather Kidd.
Heather Kidd, Councillor for Cherbury and Worthing, nothing to declare.
Thank you, Heather. Hilary Knight. Janet O'Loughlin.
Janet O'Loughlin, I'm here. I'm a co-optee for Telford and Wrekin.
Thank you, Janet. Councillor Stephen Reynolds.
Present. Telford Joint HOSC. Nothing to declare pecuniary.
Thank you. Dag Saunders. Councillor Mad Shinton.
Councillor Mad Shinton, Clibberry Mortimer Division, Vice Chair of Health Overview and Scrutiny for Shropshire. Nothing to declare.
Councillor Derek White, Co-Chair of the committee.
Present, nothing to declare.
Thank you. Well, there's a couple of people that might join the meeting later. We've had a few technical difficulties this morning, so we'll just continue, and as and when they come in, we can pick up their interests if they have any. Can I ask other participants who've been invited to the meeting and officers who are also asked to confirm their presence? David Evans, Accountable Officer, Shropshire CCG and Telford CCG.
Present, Karen. Nothing
Thank
to
you.
declare.
Councillor Angela McClements. Chair.
She's hoping to join the meeting a bit later, Chair.
Okay, thank you. Councillor Kelly Middleton. Councillor Peggy Mullock.
Here, nothing to declare, and I chair the People Committee at Shropshire Council.
Thank
Scrutiny
you.
Committee, sorry.
Thank you. Councillor Ed Potter.
Present, nothing to declare.
Thank you. Zara Bowden. Shropshire Parent and Carer Council.
Chair, Zara is listening at the moment, but she's struggling to access so she can participate in the meeting, so she should be along shortly.
Okay, thank you. Daniel, you've just answered the question. You're here. Joseph JHOSC.
Telford and Wrekin Democratic Services and Scrutiny Officer, present.
Thank you. Stacey Worthington.
Present, Telford and Wrekin Senior Democratic and Scrutiny Services Officer.
Thank you. Amanda Hollyoak.
Yes, present, Chair.
Thank you. And Lynn Corley. Is there anyone else present that I've not mentioned? I'm taking that as a no.
Chair, we do have Andy, Councillor Andy Burford here.
Oh, of course, Councillor Andy Burford, welcome.
Hi, Karen. How could you forget me? Yes,
No.
present and nothing to declare. I have to leave the meeting at 11, unfortunately.
Okay, but you're very welcome. Thank you for attending, Andy.
Thanks.
We'll now turn to the items on the agenda. Have there been any apologies for absence?
There's no apologies for absence, Chair, and we're working on getting absent members in as soon as possible.
Thank you. Disclosed pecuniary interest, we've dealt with those. The minutes of the last meeting, the minutes of the last two meetings actually of this committee will be presented for approval at the next meeting. We've had some issues, personnel issues with sickness and capacity, so I think we have to accept those constraints and accept them at the next meeting. So we'll now go on to item 4 on the agenda, which is children's mental health services. That should now be up on the screen. We've got David Evans, the Joint Accountable Officer, Shropshire and Telford and Wrekin CCGs, to speak to the paper that has been circulated to the members. Thank you, David. It's over to you.
Thank you very much, Karen, and apologies that I wasn't able to attend last week when Kathy Riley from MPFT also gave a presentation. It's just diaries at the moment, unfortunately, are a bit tricky, as I'm sure you can imagine.
Yeah.
So I just want to take you through the paper very quickly before I leave time for questions and examination by Joint HOSC members. We started a transformation programme around CAM services about 3 years ago now. Previously, as you will recall, it used to be provided by Shropshire Community Healthcare Trust. We felt that for a number of reasons, one of which was to deal with the transition period from children moving from children's services at 18 into adult services. It would be much better if we had a more integrated approach to dealing with children and young people as they make that transition period. So we looked at re-providing the service, or having the service re-provided. It's now provided predominantly with partners by MPFT, and it covers children from when they're born up until 25, so that you get a good transition period from 18. One of the challenges that many systems in the country face, not including ours, but not least ours, was actually children, if they are in mental health service provision during their childhood, at the time they were 18, switching over to an adult service proved quite traumatic for children, partially because, of course, they've built really good relationships with the mental health teams as they've gone through their childhood, and to suddenly switch to having a different team just because they've had an arbitrary date of their 18th birthday never really felt the right thing to do. So that was predominantly one of the reasons why we wanted to change the service, become more mainstreamed in terms of that transition period, so that during that period, both in late teens and early adulthood, children started to build the relationships with adult services as well as the CAM service as they go through that period. So we are seeing, as you would expect, increasing demands on the service as we've not just gone through COVID, but certainly pre-COVID. In terms of where we currently are in terms of access, we are exceeding access targets, but notwithstanding that, I think a target is relatively arbitrary in that sense. I think what's much more important is the level of support that children and young people are getting through the service, and trying to make sure that we've got as good a quality service as we can that intervenes early when a child's mental health begins to cause concern, so that they don't run the risk of escalating and needing further services, and particularly around tier 4 beds, which are, although they're commissioned by NHS England rather than the CCGs, tend to be, one, difficult to get hold of because there's a significant demand for them, but two, we don't have any tier 4 beds locally, so it therefore means that children would have, and young people would have to be cared for in another part of the country, which makes family contact and contact with friends much more difficult. So we are committed to looking at how we try and integrate services across the whole gamut. So that includes social care, it includes health services, including primary care, includes things like education, to provide the best possible support we can for young people and children to prevent them having to go out of county. I'm not going to particularly go over in great detail the service itself, because I'm sure members will want to pick that up, particularly in light of the conversations they will have had with Kathy Riley last week. We do look at CAMS really closely in terms of our assurance and our assurance framework, and indeed I've just come off a call prior to this where we were looking at two particular young people who are currently on the paediatric unit at SATH, who are requiring high levels of intervention, to see what else we can do with those children in terms of support, both for them and their families, to prevent them having to go into tier 4 beds. So that was probably all I was going to say in terms of the report itself, Chair, because I thought it was more important that we opened up for discussion and questions.
Okay, I'll start the ball rolling, David. And you started your introduction by describing this extended service from which was previously 5 to 18, I think, wasn't it? So we've got a bolt-on of 0 to 5, and then at the end 18 to 25, so that it covers that whole range. But I just wonder, because in the paperwork that you sent us, here it says, it talks about the BU, and it's that first paragraph, and it says it's available to children and young people up to the age of 25 years of age. New referrals are being taken for people under 18. Existing patients will be supported until they're 25. So what happens to young people at the moment if they're referred into the service just before their 18th birthday, or just after their 18th birthday?
So normally, once you would hit 18, you would hit adult mental health services. So they wouldn't be referred in for children's mental health services. They would go into the adult service. Now, certainly some of the people that are working in the BU service also work in adult services to make sure that we get that transition right. So it is quite possible that they would come across some of the team that are currently delivering within the BU service. But in general terms, someone who is either just approaching their 18th birthday or indeed has gone past their 18th birthday would be referred into adult mental health services.
I can't quite get my head around that. If it's a 0 to 25 service, why are you cutting off referrals in at 18?
Because the reason to keep this service there for 0 to 25s past a young person's 18th birthday is if they have already built up those relationships with the team, to make sure that they then transition into adult services later on, and they already have built relationships with the adult service because they form part of that BU service. Of course, if you're just being referred in at 18 or around about 18, you won't have had the long-standing relationship with the CAMS service, and therefore it's okay in that sense to just be referred straight into the adult service. It's about making sure that the transition works, Karen, because clearly one of the difficulties is if you're a child of, let's say, 10 or 11 for just as an example, who then has been under the care of the CAM service for 7 or 8 years, to have an arbitrary cut-off date at 18 where you suddenly lose the team you've been working with for 7 or 8 years and suddenly have to develop a brand new relationship with a completely brand new team that you may never have come across before is quite difficult and raises a lot of anxieties. Tends to, the experience has shown previously, tends to put that child's care backwards rather than transitioning forwards, and that's the reason why locally and indeed a number of other services across the country have looked at how do we make the transition better, and that is about trying to get those adult teams and children's teams working in that 7-year period between the child being 18 and into 25. But of course, as I say, if a young person at 18 has never had contact with the children's mental health services, you don't need to make that transition in the same way.
Okay, yeah, that explains that, David, and also we can explore that in a little bit more detail. Just so that everybody's aware, you know, the mental health services we've tried to break down into manageable size pieces of work. I think we've totally underestimated exactly how big those pieces of work would be, but so be it. So we've got children's services, which we're looking at the moment. Then we want to look at the transition point that you're talking about, David, and then we want to go on to adult services. So we'll probably go into that in a little bit more depth and explore exactly what that looks like at the moment. I just wonder if you can go, I'm still on page 2 of the information that you sent around. The Tier 4, would that be getting more help, or is that intensive help?
That's intensive help as an inpatient, and it's very specialised support. So Tier 4 beds nationally are commissioned by NHS England Specialised Commissioning. They're not commissioned by CCGs, so they tend to be very high intensity units where children are seriously ill in terms of their mental health. That could be around a number of things, which would include obviously serious mental illness in terms of things like schizophrenia or other conditions, but it would also include potentially some things like anorexia for very severe cases in terms of a child's mental health. But they are commissioned by NHS England. We don't have any Tier 4 beds locally.
So is that getting intensive help? I'm just looking at the steps that you've got.
Yes,
so getting more help, that is still within your remit. That falls under your commissioning capacity. Up to
and including Tier 3 remains the commissioning responsibility of the 2 CCGs. Yeah. Tier 4 is a commissioning responsibility of NHS England.
Okay. But I wasn't sure whether it was the intensive help or whether it was getting more help.
No, it's help. Sorry, Karen. It's a graduated approach. Clearly, as a child or young person goes through Tier 1, possibly escalates into needing Tier 2 type services, possibly escalates into Tier 3. By the time, which hopefully we can avoid as far as possible, a child escalating into Tier 4, at that point the commissioning responsibility in terms of a Tier 4 bed, because that is inpatient care, becomes the responsibility of NHS England. However, if a Tier 4 bed is not available at the time a child needs it, under the Mental Health Act, the CCG has to make alternative arrangements for that child until a Tier 4 bed becomes available. Now, that would normally be either a bed in a paediatric unit with high levels of mental health support from a specialist mental health team to support the staff in a normal paediatric unit, it could in exceptional circumstances be the child still cared for in another setting or at home, but again it would require intensive support from a mental health team and is not ideal.
Yes, I can see that would not be ideal. So you say we have a couple of young people at the moment in that situation at the moment within our hospital.
We do, yes.
And is that normal? Is that what you would expect?
Yeah, I wouldn't normally expect to have a couple of children at the same time requiring Tier 4.
But it's not an uncommon practice.
It's not an uncommon practice for a child to present at an A&E department seriously unwell and get admitted to a paediatric unit until a Tier 4 bed can be found for them. But as I say, they are difficult at the moment in terms of they are in short supply. There is a national problem with them. It has been escalated to the highest level within NHS England, but there is a recognition there is a greater demand than there is currently capacity for nationally around Tier 4 beds.
And are these young people who present, I mean, I know this is a hypothetical, but they present at A&E, are they generally, they will have been on the radar, presumably, of mental health services. They won't just present at that crisis point.
No, they will have been receiving care, some for a considerable number of years, but they have reached a crisis point. That may have translated itself. The reason they may end up in or may turn up at an A&E department, for example, may be around some self-harm in some shape or form.
Yes. I think in Telford and Wrekin, I don't know if Telford and Wrekin councillors want to pick this up, but they're flagged red, aren't they, for numbers of young people in their public health data. They're flagged red for the number of young people presenting with self-harm. So I wonder if that is, we can maybe touch on that later and how that's affected some of your commissioning intentions for Telford and Wrekin. Can we just go back to that referring into the system described on page 2? Who can actually refer into that system? And who progresses the child to the next stage? Presumably, it's once they're accepted into the system. It's the BU support workers, is it?
Yes, so normally the referral route would either be through GP or through education or possibly through social worker. And the level of support required would be determined by the BU service as the clinical team involved in that child care and support, and they would as with other long-term conditions, they would then determine when that level of support needed to change.
And so parents, can they refer their child into this, or do they have to go through their GP or the school, for instance?
They would normally go through the school or a GP. However, if a child is in the service and, for example, parents or carers are concerned about potential deterioration in the child's condition, they would just ring the service in the normal way. They wouldn't have to go back through that loop of GP or social worker or education.
Okay, and is there anything, because getting help is a time-limited service. It's described as time limited. Is there anything which would put the young person back to the beginning of the referral? And I don't like to use this word, I can't think of another word, but if there's a failure to comply because it's a time limited service, or what's seen as a failure to comply, are they then told, or is there a possibility that that person is then told, no, I'm sorry, you have to start at the beginning again, or you're off the list?
The only time that would occur is if a child was actually discharged from the service completely. Now that does happen in some cases, because if a child, for example, has presented with anxiety or indeed depression, it may well be that, as indeed with adults, at a point in time, that child no longer required that level of intervention. However, in most cases, if a parent then rang up the service to say, I'm getting concerned about my child again, they would normally see that child rather than having to say, go back through your GP.
Okay.
Because we are dealing with different, we are dealing with a different group of people here, where not only is the child themselves unwell, but for very, very understandable reasons, family and carers get anxious about the child, understandably so, and so we do try to make it as open a referral pathway as possible once someone is on it.
Okay, it's just anecdotally that there have been descriptions of a different approach, if you like, but I don't want to go into those because I don't personally have experience. I've got Zara Bowden who'd like to ask a question. Zara.
Thank you, Chair. David, you've talked about the service having 2 referral points of schools and GPs. There's a few things in what you've said that concern me slightly, in that firstly, we have parent carers across Shropshire and Telford and Wrekin who speak to both PAC and PODS as the parent carer forums that support both local authority areas, where they describe a service where the GP referral system doesn't work appropriately, and quite often they get batted back out of the system unless school have submit the referral to the BU services. But the challenge with the school referral system is that quite often the child has to be presenting those difficulties in the school environment for the school to be able to support the parents' concerns. And as you will appreciate and most likely understand, many of those children actually don't present a lot of those problems in the school environment due to the structure and the support that's provided, particularly for primary school age children. So we have a concern there with regards to the referral system in the ability of it to enable a good referral to take place. There's also some concerns that are being raised around the quality of the information and the quality of the assessment process of that information. And where you're talking about having BU effectively triage and determine the pathways for those young people to go through the mental health service, the information that we receive from families quite frequently refers to them being discharged without a conversation whatsoever, where they will receive a letter to say you've been referred into the service, we've had the information, but we've discharged you. And the family haven't had an opportunity to talk to any practitioner on any level, whether they be a triage practitioner or a clinician or even a diagnosing clinician, to be able to explore what their needs actually are and what the concerns are for the young person in all environments, not just the environment referred to in the referral documentation, which again, quite often families don't see that before it goes in. And again, the fact that the current referral process is managed and assessed and a determination of pathway without clinical engagement or assessment of the family's whole picture, looking at the holistic situation, is quite concerning. And we have raised concerns about this regularly, and we've spoken to you directly about some of these concerns as well, and we're still not satisfied that the assessment of children's needs in the variety, particularly around the neurodevelopmental needs of young people, ensures them the right support at the right time through the current mental health system. The other mental health services that sit within VU, such as eating disorders, anxiety, depression, seem to work much more effectively. But for those with neurodevelopmental conditions, where they also suffer with those mental health conditions, we really struggle to see where families can get the right support at the right time, because they're either being fobbed off with just dealing with the anxiety or the depression, or they are being told that until they have a diagnosis, which they can't obtain because they haven't had the right referral through, they can't go down the neurodevelopmental pathways that we currently have in existence, which, if we're honest, aren't effective and aren't really neurodevelopmental pathways. What I'm struggling to understand here is how the CCG have got to a point where we have a dynamic support register, the CETR assessment process that can manage that upper level of the system, and we have intelligence from that tier 4 level of the system to help us to understand where the failures are further down in the early intervention levels that we're talking about now. How has the CCG not managed to commission services appropriately based on the fact that you have that intelligence available to you to enable a more effective commissioning process? And how can we support you moving forward to ensure that that commissioning process is more effective in the future?
Thank you. So a couple of comments. I mean, it's part of what you described there sounds a bit catch-22 to me, so I would like to take that away and have a look at, because it's impossible to see how you could get a diagnosis if you can't get a referral in the first place. So clearly that's not acceptable, and I would like to talk to my team about that and how we can improve that. The referral pathway should work, so I'm slightly puzzled as to why there continue to be problems, because I know we've been working on this with the providers. So I will take that away, and perhaps we could have a conversation outside in a few weeks as to whether or not that has then changed again, or whether we need to do some further work on it, because clearly it doesn't matter or not what the presenting condition is that the child is exhibiting. And I take your point entirely around schools. There should be an easy pathway that when someone is triaged, it is assessed appropriately, and the right information is either given to parents, or there is a discussion with parents as to why ongoing support is not the right route at this point in time. So clearly, if that's not working, we need to have a look at that, and I will take that away, as I say. In relation to your further point around escalation of children and young people, I think it's fair to say that the earlier we can intervene with children and young people, the greater chance there is of those children and young people being supported and provided with the right level of care at home, or as close to home as possible, so that they don't escalate into tier 4. We redesigned the service, as you are aware, about 2 or 3 years ago when we started the BU service. We thought that was the right service to enable, as far as is possible, for there not to be an escalation into tier 4. We are continuing to review that, and we will be looking at, are there changes we need to make to how we commission the service to improve it in relation to making sure children don't escalate. Again, I'm happy to have a conversation outside there.
Okay, I've got Heather Kidd who wants to ask a question, presumably on the same line.
Yes, I've had experience of a young person who was in fact adopted, and there were all sorts of issues, and there were quite a lot of support and so on. But most of what was diagnosed were behavioural issues. And you can sort of see that, but he had suffered from fetal alcohol syndrome and so on. The real problem came when he went on to, he was 16 and went on to further training, and the linkages were broken, and it was very difficult then to get him to a GP. So the referral paths became very difficult indeed. He really didn't get any more help, and I did raise this with education itself, who said no at 18, because it really got to a crisis just about a week before his 18th birthday. No, we don't deal with this anymore. He's going to be 18, and by the time we got to 18 they wouldn't do any more. Now there is a window there now, and the law had changed, and it had been changed for a while, but between 18 and 25, certainly adopted children, but actually all children who've had a history should have had continued care, and it becomes then very difficult to get that individual young person to engage either with a GP or with anyone in college or whatever. And I don't know what you do about that, but actually not picking that up has had all sorts of ramifications that are ongoing to this day. And sometimes these things are not thought of as being mental health issues, but just behavioural, and it's not the answer.
Thanks, Heather. It's difficult to talk about individual cases, as I'm sure you will appreciate. And in a sense, one of the things you're highlighting there is exactly why we wanted to move away from a 0 to 18 service into a 0 to 25 service, or 5 to 25 service, because of that transition period. Clearly, that's a bit more complicated in relation to education, because unless a child is going on to further education or university, they probably are stopping their education at between 16 and 18 and moving into either work or some form of apprenticeship or further training that education may not have direct responsibility for. So that is a bit more complicated in that sense, but nonetheless, the remaining elements of the service around supporting that child through the transition period from 18 to 25 should still be there, including their GP, unless for some reason they've had to move away, and that would bring them into a different area team. But again, there should be conversations going on between the originating area team and the receiving area team, for want of a better word, to try and smooth that transition as far as possible.
Just to come back on that, he lived here since he was 7, so actually it was our area. He continues to live here, and he went into an apprenticeship, which actually he lost because of his issues. He's now just lost the second one. So there are significant issues and ramifications for society as a whole. And yes, it's difficult to talk about an individual case, but that will happen not just in this case, it will be happening in lots of cases. And we need to find a way of making that a little more reactive. And it was very difficult for his parents, who now cannot live with him, to actually even refer. They kept coming up against brick walls, and that's my issue, because I don't want to see other young people in my area go through exactly that.
No, I suppose, I mean, maybe we need to have a conversation outside, Heather, because what I can't explain here without knowing more detail, and it would be inappropriate to go into great detail about an individual case in a meeting being held in public, is why, if he, I think, was already in the service, why that made it difficult for the transition. I get the education bit about moving from education into an apprenticeship, but if he was receiving ongoing support from the BU service as a whole, the rest of that support should still have been there to try and help ease that transition from education into an apprenticeship environment. And certainly his GP would still have been there.
Can we just go back a little bit to the points that Zara was making a minute ago about I don't want to use the word failures, but actually maybe something inadequacies around the commissioning into those lower tiers, because she said, I think she mentioned that they quite clearly have been identified by the tier 4 requirements. And there's a question for me about how did you, and what evidence were you using, what information were you using to support the commissioning of this service at those lower levels?
So as with commissioning any service, irrespective of whether we're talking about CAMS or some physical health or adult mental health services or community services or whatever, we would normally look at the level of need within the population and look at what the current evidence base is around best practice for that service, and clearly within the available resource then determine how best that service could be provided. Now, in a sense, part of what Zara is describing is why I think that the direction that commissioning in terms of CCGs is changing, because we are, as you know, moving into a future where we move away from what's called transactional commissioning, i.e. we pay for every treatment for someone, assuming it's under tariff or payment by results, and moving into a system whereby we become much more concerned about the outcomes for individuals and commission based on outcomes. And we then look at an alliance of providers to determine how best to deliver care for those outcomes based on the sum of money that is available. So I think there has been a risk in the past with commissioning services, and this isn't just about this service in general, about how we have, in a sense, over-specified what we expected a provider to deliver at a certain point in time, which maybe has slightly lost the point of where we were trying to get to in terms of the outcome. So I think just picking up on where I started off, we would look at the need, we would look at the evidence base in terms of best practice and the best outcomes that could be achieved. And that's where we need to change the way that we commission services so that we focus around outcomes and we work with providers to make sure they deliver against outcomes rather than delivering something at a point in time which may be missing the point slightly.
And I'm just wondering here, when you're designing that that service based on outcomes, are you co-producing it with, and I'm thinking again of our PACs and our pods, the parent carers, those people who are at the coal face, if you like, of need?
So Claire Parker, who's the Director of Partnerships in the CCG, and myself had a Teams meeting, I think about a month ago now, where we gave an absolute commitment around co-design, because, you know, at the end of the day, whilst we may have some knowledge, or I hope we have some knowledge, about the needs of children and young people and their families and carers, clearly we don't have the expertise in terms of that knowledge that parents and carers and families do have, and indeed the children and young people themselves do have, about what is required, what works best, and what the right level of support and intervention is. So we are absolutely committed to co-design, and Claire and I were very clear in that meeting about that.
Thanks, David, because we heard last week and there were some frustrations vocalised about this whole thing about co-design and the emphasis and importance of it. And it's at what point do you work and collaborate? I think there was a feeling of frustration, and forgive me, Sarah and Zara, if I'm putting words into your mouths, but there was a feeling of frustration that the service provider had designed something and then went to the likes of PAC and POD and said, what do you think about it, rather than involving them in the very beginning. And if I've misinterpreted that, I apologise, but there was a considerable feeling of frustration with this whole co-production of services last week when we were talking to the provider. I've got a couple of people who want to come in. I'm going to ask Councillor Derek White to come in, and then Zara wanted to come back in and comment further. So Derek.
Thanks, Karen. Hi, David. How are you doing? David.
I'm good, thank you, Derek.
Look, I think we've really got to, I don't want to go back into CAMHS. CAMHS was a disaster. There was 2-year waiting lists, people were never seen, and there's lost generations who have never had the support and help that they should have had. And we are going to have to pick up that tab later on. But what's very clear to me, and what's been through the conversations that I've been having, and also the figures that has been supported, is that we have traditionally in Shropshire, and Shropshire as a whole, been a very low contributor to mental health. We are below the national average in the amount of money is contributed. Now, firstly, I will hope that will be addressed. That I also think that when the MPFT took over the service, they didn't realise what the problems really were, and that's been almost confirmed by a thing. When talking to BU, they've actually said that they had very little money and that we are not getting the resources we are. Lately, you've actually put some more money into it, but for specialised services. Now, the problem is, if you build a service on sand, you're going to end up with cracks in the wall later on, and that's what we don't want to see here. I actually went on Facebook on the page that I run, and within an hour there was 36 people who had been engaged within the Sutton Hill area, and every one of them had negative reports about what's happening, and the failure for children to be able to get into the service in the first place. They're a real problem. People being knocked back time after time. 11-year-old kid trying for 2 years, and only now are they getting a telephone conversation. And this is with the support of schools, it's with the support of support workers, the whole lot, all saying they need help. But for one reason or another, they're getting knocked back out of the system. And that cannot be allowed to continue. We really need to have, are you actually going to do, as a combined CCG now, are you going to be putting a lot more money into the system? Because I'm really pleased to hear that you're actually wanting to do results rather than actually, just by having a service for a service sake. But you said again and again, within the constraints of the finance. The problem is the COVID years are going to cause a major kickback on our kids and the whole family's issues for a long time to come. And you're going to have to invest a damn sight more into mental health services, especially trying to deal with what's happening within the schools today.
Thank you, Derek. So there's a few points there I'll try and pick up. I think, to be fair to the BU service, the previous model of care in terms of CAMHS, I think, was probably old-fashioned and outdated. And I think that's given the BU service some challenge around constructing and delivering a new modern service. Have we got it right at the moment, either in terms of commissioning or indeed delivery? I think there are significant challenges there, and I couldn't hand on heart say it's an absolutely perfect service, because it isn't. And that's both in terms of, I think, the way we've commissioned it, but also the way it is being delivered. And we have a joint responsibility there to get this right. And clearly, if families and young people and children are finding it difficult to get referred into the service, then we need to do something about that, and we need to look at that urgently. And I will pick that up outside of this meeting. The money's always going to be a challenge, and we know that. And I'm not going to use money as an excuse here, because I don't think that's appropriate in the context of what we're talking about. However, we do have an overall financial envelope. Now, what I couldn't say to you today is, if I looked at the overall spend on mental health services across the whole of Shropshire, Telford and Wrekin, do we get the best we could out of the money we spend, notwithstanding that we probably need to invest more, and I would accept that. But I couldn't actually say that we are getting the right level of service at the right time for all of the population in terms of that service. So there's a question there for me that we need to have a look at. We are committed to making sure that the additional sums of money that come down from the government into mental health services, so we meet the mental health improvement standard, and we are absolutely committed in the 2 CCGs and the single CCG moving forward to continuing to invest the money that comes down into more mental health service provision excuse me, for our communities. Would I like to go further than that? Yes, I would, but I will need to take that money from somewhere else in terms of another part of where I spend cash. And at the moment, we haven't clearly identified where we could do that. But we are absolutely committed to spending more in terms of the mental health investment standard. I want to be absolutely clear that where we are spending money, we're getting the best we can for that money, and if not, redirecting some of that in terms of mental health, as I would about any other service. I don't just mean that in terms of mental health. I'd say exactly the same about acute or community or whatever. And would I like to spend more in the future to further enhance and improve mental health provision? Yes, I would, but that bit's a bit trickier because we need to identify where we could take that money from.
But David, when we commission a service, what we don't do is just take on something that hasn't worked, and that initially happened with BU, and only now are they changing. The reality is that from even the discussions with BU is this discussion with pods, the discussion with schools. We're only just getting to the schools by having emergency teams and all the rest going out trying to talk to, and in Shropshire that hasn't been rolled out. And that is sad, because this is where the source is. £1 saved in schools today is £1,000 saved in mental health action later on. And we have to actually make sure that this is a major investment, and we have to do this. But you have got to get the service right, and you're not going to get it right by basing it on an old service that was clearly not working. We have got to start from the very start, and that means, you know, it's 4 years, we're nearly 4 years into it, and we're only just discussing starting to talk to pods. We're only just starting to listen to schools. We can't go on that way. We've actually got to start and say, look, let's start and talk properly. Let's have the discussions now. While we've got the opportunity, let's see what we can do better. Let's see where we can go from there. And that is absolutely vital, rather than spending more and more money on services and getting people in there and getting people that can do diagnosis. We are struggling like hell, and we are told this is a national phenomena. So what are you going to be doing about that? Getting the people that can, without a diagnosis, You know, you're putting your finger in the wind and you're licking your finger and putting it in the wind and hoping the wind's blowing your direction.
No, I'm absolutely clear, Derek, that we need to do things differently, and you know, it's part of the reason why I am so so clear that we need to look at early intervention, not just in terms of children and young people's mental health. I mean, I would say this about any service, including adult mental health services. You know, we've got children currently in other parts of the country being cared for in residential settings or inpatient settings that are costing a significant amount of money as individuals, never mind collectively, as individuals. Clearly, had we, but the reason they are there because they will have their condition will have changed over a number of years. It's not a sudden thing in terms of deterioration in mental health in either children or adults, indeed. What we need to do is, and I'm really clear about this, is have the right system in place that allows children to be referred into appropriate services to prevent their mental health deteriorating to such an extent, because that's not good for the child. It's not good for their parents or family. Now, the CCG cannot do that in isolation. We need to work with local authority partners in terms of particularly education around how we can do that, and other parts of local authorities as well, because we know some of the component factors around that influence mental health for all of our society, never mind just children. We need to work with parents and families to make sure that we both co-design and co-produce the right services for children. Now, I can continue to talk about the past, but I don't think that's particularly helpful. I think what we need to do is be really clear about the direction that we want this to go in, and I'm really clear, and my team are really clear, that we want to design a service that intervenes in the right way as quickly as possible to make sure that children can lead full and fulfilling lives, both as children into young adulthood and into older adulthood, so that we give them the best start in life we possibly can, because we know that the long-term benefit of that for them as individuals is much better, and the long-term cost for society is much better.
If the chair will allow me just one more point.
Mm-hmm.
Thank you. David, can I ask you to actually convene, or not you, but mental health, children's services, whatever you want to call it, to convene a meeting of all the people involved in the mental health service, talk to them in an open forum. I mean, scrutiny is not the place to do it, but we invited them along because they are very much in the coalface, because they are representing people who are suffering day to day in this. Can I ask you then that we could get a group together, talk together, listen to what's happening, then let's start looking at what, before we start actually piling money into the wrong direction. Can we actually make sure that there's a very clear conference where we can talk, listen, and be able to communicate either and say, this is what we're planning, this is what we hope to do, this is, you know, what do you feel about this, where do you think we should be ploughing our money into? And that's my last comment. Sorry.
I mean, as I said earlier, Derek, Claire and I did meet a few weeks ago. I'm more than happy to convene another meeting. I think it would be helpful to have providers there at the same time, rather than it just being commissioners and families and pod and pack. But yeah, I'm happy to do that.
Yeah, I just think we're in a technical age now where we've never been more, you know, able to talk to each other at least and listen. Thank you, David.
Thank you. Zara indicated that she wanted to contribute further. So Zara, are you there?
Thank you, Chair. Yeah, I'm gonna work backwards and just share some of my thoughts based on what I've heard in the last conversation, but also some of the thoughts I've gathered along your responses, David. So working backwards from Tier 4, obviously those are the most challenged young people when it comes to the complexity of their needs and the level of intervention and service that they actually require to manage and support those needs and to assist them in overcoming any barriers to becoming responsible and managing those needs on their own independent level, and potentially with the hope of them coming back into the community services if that is a viable option. One of the things I would like to pick up on the Tier 4 system is that, rightly so, some young people will be placed into Tier 4 beds. They will be placed into a mental health facility or they will be placed into a residential facility because that is actually the most appropriate place for them at that moment in time. And the last thing I want anybody to take away from these conversations is a sense that it is wrong for young people to end up in Tier 4 care, because actually it can be the perfect place to address their needs at that moment in time.
Zara, I wouldn't disagree with that at all. And if I gave an impression that there aren't circumstances where Tier 4 is appropriate, then I apologise for that.
No, you did. I just wanted to clarify that was where we are really, because I think, you know, for some families whose young people do end up in Tier 4 for a variety of reasons. Firstly, we don't want families to be frightened at the prospect of Tier 4 because actually it is the right place at the right time for many young people and their families. But also it's around people understanding that the transforming care agenda isn't about bringing people out of Tier 4 beds for the sake of not spending money. It's about reintroducing those young people back into society in a way that works for them where it's appropriate. And in Shropshire, we do need to recognise that we have quite a low number of young people who hit that transforming care agenda anyway. So in reality, our job is already challenging because they're already there because that's the right thing for them to be doing at this moment in time. Moving down through the system, understanding, and as I've said before, from the dynamic support risk management system, so we have a dynamic support register, which is a national agenda that every CCG has to hold for young people who are identified through key indicators within the health system around they may end up in either a mental health Tier 4 facility or a residential facility due to the complexity of their care needs. Again, my point around using the dynamic support risk management systems to inform and influence our joint strategic needs analysis, of which we need a SEND specific one in Shropshire and Telford and Wrekin, is crucial in helping us to manage and mitigate the early intervention pathways more effectively. Actually, those young people who end up in that place at that point in time, they end up there quite possibly because the system hasn't worked for them lower down in Tier 1, 2 and 3. And if that's the case, what do we learn from that? How can we inform and influence the rest of the system to be responsive to that rather than firefighting all the time? Moving a bit further down the system, we have young people who are currently accessing the BU service at the higher end of need, who may be specifically working with the learning disabilities team or maybe awaiting an autism diagnosis or maybe in post-diagnostic support. Now, you've rightly identified this isn't just a CCG responsibility, this is a local area responsibility, and the local authority has a duty to support you in the delivery of meeting these needs. And rightly, we've all been working hard to achieve a co-production model that ensures the local authority and the CCG take joint responsibility and work in a joint partnership approach to ensure that the rest of the service, such as the early help and targeted support level and the disabled children's teams across both social care services, appropriately respond to the need that is not met by the health element of the service. The system needs to be reflective of young people who are diverse. Currently, the system doesn't have the flexibility built into it, and we've heard from a previous speaker about a young person within her constituency who wasn't able to access services at the right point in time. And actually, it sounds like that young person had a multitude of needs that were all going unmet at once. That speaks to the point that is raised regularly by families where we're referred into a mental health service for one thing because that triggers the referral process. But actually, our young people have a catalogue of needs. They might have autism that may or may not be diagnosed. They may also have depression. They may also have an eating disorder because of sensory processing difficulties. They may also have a tendency to self-harm when they are unable to regulate their behaviour and their emotions and manage the situation well. For me, the system currently is not reflective of the diversity of those young people, and moving forward, I would absolutely welcome a commitment to ensuring that a triage system, however that is collaboratively co-produced and brought into fruition through the appropriate commissioning process, that system needs to allow for multiple pathways to happen simultaneously so that young people's needs can be met in a system together rather than, right, let's deal with that bit first, tick, that isn't the problem, or that is the problem, brilliant. Now let's move you on to this service and start working on that problem. These young people can't compartmentalise their needs in the way that we seem to be compartmentalising the service. And I feel as though through the work that I do with PAC and through the work that Jane does over in pods, and again from a regional perspective, you already know that I am the regional director for the National Network of Parent Carer Forums in the West Midlands and have a really close working relationship with the learning disability and autism team and the mental health teams in the West Midlands, and have a better understanding of where we're heading as a region with our mental health services in the future. And it feels to me like this is the path we need to take, being more responsive but proactively diversifying the service. What I'm hearing though from the providers and what we heard last week is that they're not equipped to do that, either because they've not been commissioned adequately or because their service doesn't cater for that need in the way that we need it to. And it might look different in Shropshire to how it does in Telford and Wrekin. I just want to make it crystal clear that we need to work together, and I absolutely respect and understand you want to move forward with this and not be reflective of the negative connotations of the previous system, because it doesn't help to rehash the past, absolutely, but we need to learn from it. The previous commissioning process for the current BU system, the commissioning process itself, we felt we had a voice as representatives of our community. We felt we had plenty of opportunity to inform and influence the commissioning process. What wasn't clear was that we were heard in a way that resulted in a positive commissioning experience and gave us a service that was fit for purpose. And for me, moving forwards, it is about co-producing from the beginning. And the point that the chair has raised around the concerns raised last week, that we haven't felt that the service has co-produced the service. We've been involved in the commissioning of the service, but actually we haven't co-produced the delivery and the operational model of the service. And that is where currently the failing sits, is that the service doesn't work. And I just feel that we need a commitment from you to take responsibility for driving that forward, because it is the CCG as the commissioner who should be setting the expectations for the provider to be meeting that, and whether or not that needs to be built into the commissioning process as a KPI, that they are able to strive to achieve that. We need to discuss that further, because for me it just feels as though we hear the right things from you as a CCG, but we never see it actually results in families' experiences improving. And we know this is going to be a long drawn out process. And what I would like to say to any parent carer who is watching this is we have been working so hard on this for such a long time, and we do appreciate that the conversation has changed dramatically in the last 4 years, but it needs to be resulting in action that families feel now?
Thank you, Zara, and recognise a lot of what you're saying there. I mean, it would. This is going to sound slightly flippant, and I don't mean it in any way, shape or form to be flippant, but I just kind of want to use an analogy, and I'm using this in describing where I think commissioning used to be and where it needs to get to. And so the example I'm going to use is I take my car in for a service, because I know nothing about cars. I have one, but that's all I know. And you know, when I take my car in for a service, I expect to know the price I'm going to pay at the beginning. In fact, when I pick it up, obviously I haven't got any warning lights on the dashboard. What the garage does to it in that bit in between to get it to that point, I really don't care about. Other than if I start to actually say to them, well, actually, if it needs a new tyre, you can only use this brand. And if it needs oil, you can only use this brand. And if it needs this, that, and the other, you can only use those. Now, what I'm doing there in that context is beginning to over-specify what I expect the garage to do. And inevitably, that reduces their freedom to possibly get the best price possible. And therefore, what does it end up being? It ends up being more expensive. That's why I think commissioning hasn't been as successful nationally, not just locally, nationally, as it could have been, because what we've tended to do in terms of specifying, irrespective of whether we've involved people in terms of co-design and co-production, what we've tended to do is over-specify. And it goes back to your point about that kind of, you get someone referred into the service and you want to tick this box first in terms of either excluding or including that in terms of a diagnosis, and you then move on to something else, and you then move on to something else. That's a really inefficient way of service delivery. It's an expensive way of service delivery, and commissioning probably got it wrong because we over specified in terms of how we expected that to work. We cannot continue in that vein because it doesn't deliver a responsive service for children and young people and their families. It doesn't deliver a service that works for children and young people and their families. We've got to be much more clear around, these are the outcomes, this is what we want providers to deliver. And actually, in terms of that co-design and co-production, you have to involve, as representatives, people like PAC and PODS, because they know the needs better than we do. It's why expert patient programs work in the NHS in terms of bringing around real change, because you're actually talking to people that live the experience rather than those of us that at one point worked in an office now work from home, because we may understand the subject but we don't know the experience, and that's the bit that we need to make absolutely clear. We know the experience and we evolve, and you have to involve providers, because whilst it may be a reflection of commissioning that either we didn't get the specification right and therefore someone will stick to the specification because otherwise they're worried we're going to impose some kind of contract notice, for argument's sake, or because actually they don't have the expertise to deliver in that way, is irrelevant. What we need to do is say, what's the art of the possible? What are the needs of the population? How do we get the outcomes we want, and which providers can deliver that? And it may well be that no one provider can deliver all of it. And, you know, again, if I used a different example in terms of musculoskeletal pain, in terms of physical health, whilst of course you would need the option for surgery as the end result, the chances are there will be a whole host of interventions you would try before you got to that point, because surgery actually has the risk of complications and is not something you'd want to put someone through because there's a risk associated with it. So it's how do we get the right design here that works? And I'm absolutely clear that I don't want to continue with the way we currently deliver children and young people's mental health services. There may be elements of it we haven't got right, and I would completely accept that. But actually, this is about the overall aim and aspiration of the NHS across mental and physical health and well-being to how do we start to work on a different agenda that's much more around prevention and self-care and self-management and intervening at the right points to enable people to live happy and fulfilling lives.
And if I may, Chair, I think actually that's a really interesting analogy that you've used there with regards to musculoskeletal, because in reality, as someone who has recently had ACL reconstruction, I had surgery alongside physiotherapy and additional support needs were being met. But actually, our young people are entering a mental health service that channels them through, well, let's get you an autism diagnosis. No, okay, it's not that. Right, back into the system we go. And we're creating this volatile circle of bouncing around the system. But in reality, the whole point of this being a whole area approach and there being a local authority element and a CCG element of meeting need is that the early help offer and the targeted services are supposed to sit alongside that diagnostic pathway to enable those young people to have the more current and in the moment needs met whilst awaiting a diagnosis to be able to determine which pathway is the most appropriate pathway for continued support and planning into the future, which in itself creates its own intelligence around what do we need to commission into the transition period and adult services, which this isn't the time for the conversation about adult services not being fit for purpose for autism in Shropshire and Telford and Wrekin either, but that's a whole other conversation. And again, your responsibility as a CCG is the commissioning process. Part of that commissioning process is you need to hold your providers to account over co-production because they have not been doing it historically, and where they have been doing it, they've not been doing it well. And it's really important that you firstly set the example of how you expect that to be achieved, but also secondly, hold them to account where it isn't. And for me, that's the bit that I really want to see built into the system moving forward. But I do welcome, you know, your genuine response and kind of acceptance that the system is currently not working the way we want it to.
No, I couldn't possibly say it is, Zara, and you know that. And actually, your example of your own experience around MSK is quite interesting, because what was that about? That was about a multidisciplinary approach to giving you the right service for your ACL repair that involved surgery, but also involved other members of the MDT team. And sometimes I think, you know, I am a bit long in the tooth now, obviously, but when I think back to my physical general nursing career, that's what we used to do in general acute care years ago. We would deal with one specific problem, and if that didn't work, we'd move on to something else. Now we've moved away from that to a large extent in terms of physical health. We have to do the same in mental health and well-being to make sure that we do give people the right opportunities for moving forward, because otherwise we are just doing a disservice. And that's not acceptable. The one thing I would say, I suppose, in terms of we need to be clear that we want to meet need. We might not always be able to meet wants, because there is a bit of a difference there.
Yeah, I think we can acknowledge that, David, and that's not just typical to mental health services. David, can we just move on to there was a question that was posed to you around the CAMS service improvement plan. and you in response you put, and it comes on the following page, background and context. Now, apologies on my part, I printed this out because I do like to scribble on things, and I couldn't actually read it, but I don't think it's terribly important in that sense. I think what is important is that we've been touching on, well, we've not touched, we focused on co-production and the importance of that. We've also touched upon this is not just about health, this is also about local authority input. And on this improvement plan, I can see that there's a timeline, that's about all I can see on it. But at what point did the local authority, whether they are the social services, children's social services, or education, input into, and were they fully cited on this improvement plan? And did they input into it?
I genuinely don't know, Karen, the answer to that question. I'm happy to go away and check. I hope we did. And I hope that the team did do that, but can I check that and come back to you?
Yes, please, because, you know, if we've got an improvement plan that was put in place, I just want to be reassured, and I suppose that's what we're looking for, is that reassurance that was this a whole system, or was it just the improvement plan put in place by the provider for the provider, and without any input or challenge from those other people who also contribute to this area.
No, I think it was definitely done by the CCG, although the provider will have had some input into it. The bit I don't know is whether we involved education and social care, and I would just like to take that away and check.
Yeah, thank you. There is another thing that's just come into my mind, and it is actually around how we as a scrutiny committee can take this particular piece of work forward, and again getting that assurance on the way that everything you're saying is actually what hopefully will happen. And I suppose it is about then tracking this scrutiny committee, tracking the co-production of commissioning going forward into 2022, because that is when the service is likely to be recommissioned, isn't it?
Yes, it is. And I suppose a couple of comments on that. I mean, one is you may like to invite me or whoever sits in this chair in 6 months or a year's time for an update. I think the bit I was going to raise is, I think I've talked about commissioning moving forward, but overall, not just in relation to this particular topic. I think it is highly likely moving forward that in the same way that BU is made up of a number of providers, I think it is highly likely moving forward that we will end up with commissioning a service that has a number of providers delivering it. I couldn't say whether they're going to be the same providers or not, because clearly we need to go through a process. But I'm much more interested actually in how do we make sure what we are asking providers to deliver is the right thing, rather than who provides it, if that makes sense.
No, that definitely does, David, and it's just how we can, you know, keep a track, if you like, of that change in commissioning contract and development of the service. I know that there was a couple of other areas that members wanted to focus in on, and I'm going to bring Dag in, because I know Dag wanted to talk about crisis supports, home treatments in place for young people with eating disorders. So, Dag, can you come in? Oh, I'm afraid, unfortunately, Dag Saunders has not been able to get into the meeting. There was just, I think, forgive me, Dag, if I'm not getting this absolutely right, I'm probably paraphrasing. I suppose it's understanding what are the crisis supports and home treatments that are in place, because you mentioned those earlier on, David, and for young people with eating disorders, and what community support is actually commissioned.
So we are just about to, or BU are just about to start a 24-hour crisis service for all children and young people in terms of mental health services. And I think, if I remember rightly, that goes live in the next couple of weeks. I can't remember the exact date off the top of my head, but that is imminently going to start. And I think that will be quite different in terms of how children and families and parents feel supported out of hours from what is currently available. I think specifically around eating disorders, we do have the eating disorder service that is commissioned by the CCG. I'm not sure of what the out of hours arrangements on that are, although they could go through the normal out of hours service. The service does work 24 hours, 7 days a week, albeit it is a fairly small service, I think it's fair to say. I believe there is support for children and parents at home, but I haven't got the specifics to hand, but I could find that out.
Okay, can you make a note of that, David? And apologies, yeah. I don't know what happened. I missed part of your initial answer, but I think I pressed the wrong button and I lost everybody. But thank you. If you could take that away and bring that information back, that would be helpful. And I'm sure if you've not been able to cover the specific points that DAG wanted to cover, we can do that via email to you. It is just really unfortunate that we've had a few technical difficulties today. Councillor Mad Shinton, you wanted to ask a question.
Thank you, Chair. I wanted to ask David, in view of his previous statement, what he's just said is multiple commissioning, which I have some reservations about, because who is going to join the DOTSUP if you have multiple commissioners, multiple providers? And that always worries me. It just seems to me that we seem to be in little segments, almost like an orange, but nobody's got the peel around the orange, so the bits don't really connect with each other. And for me, that's a basic problem. Who's joining the DOTSUP with all these different providers? Thanks, Chair.
Thank you. And that is an interesting question. So I think the reason I'd want to look at multiple providers, well, there's a number of reasons why I'd want to look at multiple providers, actually. Oh, what? No, sorry. There are a number of reasons why I think multiple providers might be the right answer to delivery of a service. And that's not necessarily just this one, I have to say. Part of that is actually, I'm not sure any one provider in a complex field, and this one is undoubtedly a complex field, has all of the, can provide all of the different levels of service you would want them to. I think that we sometimes, and again, I'm not specifically talking about this service but more generally, we sometimes forget actually that there are a whole host of voluntary organisations who can provide, with the right support and right financial support, can provide support to people in a way that the NHS isn't terribly good at, and that's particularly around advice sometimes and hands-on support sometimes at a different level than perhaps the NHS may do. So I think that's the reason you would want to look at a range of providers providing a service. And indeed, it's the same way that we're looking at the MSK Alliance in terms of providing musculoskeletal services in the future, because that is an alliance around Shropcom, Robert Jones and Agnes Hunt, primary care and SATH. Who holds the skin around the orange, or the peel around the orange, is you have a lead provider in that context, and so the contract with from the CCG is held by the lead provider. The CCG holds the lead provider to account, and the lead provider then has the responsibility for making sure that the other providers are delivering what they are supposed to deliver to ensure that patients get the right outcomes.
If I could just quickly come back.
Please do.
So sorry, Chair. The lead provider is separately commissioned then, and what would be the criteria that you would be asking for a lead provider to apply?
So actually, because I think it's really interesting, because I think any organisation could take that role as lead provider within the context of an alliance kind of contract. That, you know, you could hold individual contracts with each of the different providers, but there's no reason why local authority couldn't be a lead provider, no reason why a voluntary sector organisation couldn't be a lead provider, no reason why MPFT or another organisation couldn't be the lead provider. There are different ways of doing it, and different areas in the country have done it different ways, but probably the contract would sit with the CCG with a lead provider, but that doesn't necessarily mean it would be MPFT.
Thank you very much. Thank you.
Thank you for that question and for the response, David. Can we just, we've only got a few minutes left really. Can we just focus a little bit on part of the response that you gave to the list of questions that we submitted was that because the ASD diagnosis was not clearly commissioned, and those are the words that you used, I'm just wondering about, you know, because that was not clearly commissioned, what's the impact of that? What is the waiting list for ADS diagnosis? Because some information provided shows that the waiting list, there was no information submitted by the Midlands Partnership Foundation Trust in 2018. They didn't submit any information whatsoever. So I'm just wondering, what does that list, because you also say that there is an expected 18-week wait for 18 to 24 months. And what does that mean for those children in the older end of that range, you know, coming up to age 18, if they don't receive that diagnosis or the waiting list is so long? Sorry, it's a bit rambling, David. I hope you've got there with what the gist of the question is.
Yeah, no, I did, Karen. I have to confess I can't remember the number on the waiting list off the top of my head, but I can get that for you. This has been a problem for some considerable time. The CCG's invested last year additional money to get the waiting list down below a year, so that no child was waiting over a year. I still think that's too long, but and would completely accept that is too long. We are now investing additional monies to get the waiting list down to 18 weeks. I have to say though, with the best will in the world, because it is a specialised service and you need specialist practitioners to do it, it probably wouldn't matter how much money we invested now. It's a capacity problem around actually getting people to be able to deliver that service. So logistically, it is going to take time to get it down. 18 months to 2 years, I think, is probably longer than we would like. But I think we're being realistic about our ability and the provider's ability to get it down within that time scale. That clearly does mean that there will be some children and young people who are waiting longer than we would like them to, and I accept that.
And it's also those young people who will fall through that gap again.
Potentially, yes.
So I was then wondering, what is the priority given to making these diagnoses? Is there a criteria of priority?
As with any other condition, Karen, it would go on the presenting clinical need at that particular time. So there is a prioritisation based on clinical need.
And then the next question around this is, can I ask about how that information, how are you updated as a CCG onto the management of this list? Is it a monthly report, a quarterly report? How are you kept informed?
It's quarterly.
So it's a quarterly report. Where does that go to?
The board.
The board.
Governing body.
Okay, thank you. Zara, you wanted to come in on this?
Yeah, David, I just wanted to clarify that the waiting list for autism spectrum disorder diagnosis and assessment, and indeed ADHD and other autism related conditions, it's frustrating at the moment, and the challenge that we put to the provider last week was that it's easy to get a waiting list down when the referral system doesn't allow more people to be put on the waiting list. So, you know, where the chair has quite rightly pointed out there will be children who slip through the gap. The children who slip through the gap will require assessment at some point because they are simply not being put on the waiting list because the referral system is not adequate at the moment. And one of the concerns, the key concerns we have, is that actually there are no clinicians, to our understanding, involved in that determination of whether or not a young person actually goes through onto the waiting list or not. It feels, from parents' perspective, because they are not involved in that conversation, as I've described previously, that there isn't actually a clinical decision being made there. It is simply about the quality of the advice being received on the referral document, which quite often is being written by somebody who has no or very little understanding of autism spectrum related conditions, and is just articulating to the best of their ability the presenting needs. And it is obviously the role of the people receiving that referral to unpick and understand that, even if it requires an additional conversation with the referrer or with the family themselves or other known practitioners to that child. And we're aware the provider has pushed that the Telford model for a triage system seems to be working, and I use the term working extremely loosely there because that is not the experience of families on the ground. We feel in Shropshire that some sort of triage process wouldn't be a poor approach to take, but that it needs to have clinical practitioners involved who are able to assess those needs more broadly to support those young people to go onto a waiting list for further investigation, support, assessment, whatever comes next. So I think my concern around your feedback and indeed the provider's feedback on the waiting list is that, yes, you are getting it under control as it currently stands, but as it currently stands is not reflective of what the need is in the community.
I think that sounds like a very well led and you know, what's the word I'm looking for? I actually think that is a very focused response to actually what part of the problem could be, and that is if you haven't got somebody who is clinically aware at that stage of the initial referral, there is every possibility that that child will just be bounced around and around and around. Whereas if you go in at the very beginning with that expert clinical approach and experience, you then reduce the turmoil for that child. That just makes sense to me, David. Does it to you?
Yes.
That was a sit through suck teeth, yes.
No, it wasn't. No, it wasn't, Karen. I'm slightly surprised that there isn't more clinical involvement in the triage, and I want to take that away. And I have just made a little note to myself.
Okay, you've got quite a bit to take away.
I've made quite a lot of notes.
Okay, would you mind, I mean, I've made notes as well. Would you mind copying those over to me as well so that we can just keep track of what we need to be asking you in 6 months' time or whenever? I mean, hopefully some of those you'll be able to come back, you know, slightly more quickly on some of your takeaways. But in some of the others, that might take you slightly longer. Are there any other questions that members would like to ask? We're now at 1:45. to one. Are there any other questions that members would like to ask? I'm aware that I've led on this, and some members might feel as though they've not had the opportunity to ask questions. I'm taking that as a no. So, David, thank you for being with us this morning and providing some answers to some of the questions that we've put to you. There are still questions that are outstanding, and some of the area of work that we've touched on today will take us forward into the next part of our look into mental health services, and those being another look at transition. Joseph, I don't. Oh yes, okay. We have another item agenda, an agenda item to cover with you, David. I'm getting lots of cryptic messages popping up the side that I'm trying to read. And of course, thank you for reminding me, Joseph. We've still got to cover the A&E. So David, over to you again.
Thank you very much. I thought you'd forgotten that for a second, Karen.
I did, and thank you very much to my very, very able officers behind me who sit behind me and poke me metaphorically.
So I think what you wanted to explore today was where we are in terms of A&E activity in terms of trends.
Yeah.
Broadly speaking. So if I have got some slides which I'm sorry didn't come over to you before. I'll make sure they come over so can be circulated. If we looked at the trend overall for Shropshire, Telford and Wrekin patients in terms of A&E activity since the beginning of this year, and particularly since March, we have been running below 2019 levels in terms of activity, and at the moment it's about 17 or 18% on October's figures. That is different between the two sites, I have to say. PRH has been running a lot lower and continues to run a lot lower since than RSH. So RSH is probably only about 5% below. PRH is probably nearer 25% below overall. And again, if we looked at it in terms of how those patients arrive at A&E, PRH arrivals by ambulance is probably down about 10 to 15%. Walk-ins are much lower. RSH actually have been slightly above since June on ambulance attendances over the same period last year, but their walk-in attendances are a little bit down. They're nowhere near as down as much as PRH is. And in terms of admitted patients from A&E, in terms of those patients that have turned up, PRH are well below, running at this year in October, it was running at about 120 patients were admitted through A&E, whereas the corresponding period last year was around about 160. RSH is above on the number of admitted patients. It was about 130 in October last year and is about 145 in the October this year. So those were the main headlines. I didn't know if there were some specifics you wanted to talk about, Karen.
I'm just wondering, what's the profile, this difference between the RSH and the PRH? Have you any understanding of what is leading the difference? Is it the age profile? Is it the actual reasons for admission? I'm just trying to understand.
Yeah, we think it's partially age profile and partially complexity of case mix, because obviously doing emergency surgery, etc. At RSH, we think has made a difference. We know from the evidence around the country that people did delay going into A&E that they may have done otherwise, which has led to more complex cases coming through. So we think it's age mix and complexity of cases and case mix.
Okay, but also it's interesting that the ambulance is slightly down in the PRH as well. So is that because, again, I'm being very simplistic, is that because the ambulance are taking them because of the complexity to the RSH?
That's the assumption, but we are doing some analysis around that, yes.
Okay. And in terms of the direction heading into winter and COVID,
yes. So we, as you would expect, have seen numbers start to go back up. We've seen a slight dip in October, but we always do seem to see a slight dip in October for some reason. But certainly if you looked back over the period June, July, August, September, there was definitely an increase in terms of overall A&E attendances. That was also mirrored in terms of ambulances, and that again is at both sites. I think there is, we've seen increasing difficulties in terms of activity levels over the last 10 days or so. We expect that to continue over the next 10 days or so, particularly around COVID and winter pressures as a combination. We did get some draft figures through from both local authorities yesterday to suggest that prevalence rates may have turned the corner slightly, and we would expect that to feed through in terms of COVID attendances probably in about a week to 10 days time. What I would say though is in terms of COVID activity at the moment, SAF have got as many patients with COVID in their beds now as they did at the peak in April. And Shropcom have also got about the same level of COVID activity as they did in April, so at the peak of wave 1. So we are coping with that better, albeit it is putting some strain on the system. In terms of ITU, however, we haven't seen as high a requirement for ITU this time round, albeit we are seeing more patients on oxygen therapy overall.
And that seems to be something that's reflected nationally. The intensity of treatment seems to be, I don't sort of to use the word diminishing, is lessening than was first seen in the, or maybe it's just we've got better at, and we have greater understanding of the disease and how to treat it.
Yeah, I think there's probably a couple of things there. I think certainly in the first few weeks of the rise in numbers in COVID, it was a younger population this time, albeit we are now seeing that translated into over 65s and particularly over 80s. So that probably had something. I think the treatment regimes in the kind of 6 months or so since wave 1 have got much better in terms of meaning that people don't need to go in for full ventilation.
And presumably the prevalence rates, because they're coming down, is that as a result of the lockdown?
That's the assumption, yes.
Okay. Well, thank you, David. I think this is something obviously we'll keep on coming back to, and it's something very much in the forefront of many people's minds as the pressure on A&E. And
Karen, please.
Yes, sorry, Madge.
Sorry to butt in like that, but
no, that's absolutely fine.
My interest really is one of our very rural GP practices had one of their patients present themselves to surgery, extremely breathless and in very poor condition, and the GP rang for an ambulance and it took an hour and 20 minutes to get to us. Now, I know we've got WV postcodes and DY postcodes, meaning Wolverhampton and Dudley, but I'm sorry, I don't accept that when a GP rings in asking for an ambulance and who has obviously had the clinical ability to describe the urgency of it, that it should take an hour and 20 minutes. So I'm not happy with the way the ambulance service is working at the moment. It doesn't seem to be clicking into first responders like it normally does. I'm not quite sure what's going on there. So could I ask David to just have a bit of a poke round? I'm sorry, that's a very unclinical expression, but to just look and see what's going on when, particularly when a GP, we're talking about a clinician here who's so concerned about his patient, he rings for an ambulance straight away and it doesn't come for an hour and 20 minutes. That's not acceptable.
No, I would accept that, Madge. I mean, I can certainly take that away and have another discussion with the Ambulance Trust. I know, however, that ambulance services across the West Midlands have been under a lot of pressure over the past couple of weeks, and they've had real problems at some sites in particular across the West Midlands in terms of being able to get patients out of ambulances and into A&E departments. And that in itself has meant that it's difficult to get those ambulances back on the road. I was hearing of a hospital in the West Midlands last week that had 19 ambulances turn up in an hour. With the best will in the world, I don't think there's an A&E department in the country that could cope with that level of demand. And inevitably, unfortunately, the knock-on effect of that means if they're delayed being able to get patients off ambulances at A&E, it takes that crew off the road until they can become free again. And that's probably the reason why it wasn't, the ambulance service wasn't able to dispatch an ambulance quicker than that. It would, they may well have determined, I don't know without talking about them, about a specific case, they may well have determined that because a patient was in a GP surgery with clinical staff there, that was less of a priority than another call somewhere else.
Right, yes, and I hear what you say, and you know, from my past experiences, I recognise that. What worries me is where they finally take the patient, because ours seem to be, because we're on the edge of Worcestershire, Herefordshire, etc. We seem to be distributed across the West Midlands region, but not coming back into Shropshire. Now, for me, quite often our people do have a closer connection, if you like, with PRH or Royal Shrewsbury. The second thing is, of course, there will be a chunk of money going out of Shropshire's budget into the other areas, will there not, to pay for our patients. So for me, this postcode thing, it's all very well to go by postcodes, but to me, there needs to be much more nuance into where the patient's coming from and where they might get support. Sorry to be a pain, but it's the thing with me. Sorry about that.
No, I understand that.
Madge.
And you know, my stepmother, before she passed away, lived in Clidbury, and I know that she used to sometimes go to Worcester, sometimes go to PRH. The ambulance service normally will, when they're making the decision about where to dispatch, assuming it's not something highly specialist that needs a tertiary centre, will normally base that decision in part on what's the local situation around. Is Worcester busier, therefore they might send someone to Telford. If Telford's busy or Shrewsbury's busy, they might send someone to Worcester instead. They kind of use that level of intelligence in determining where to convey someone so that they can get access to the right care as quickly as possible. I do accept, however, that isn't always as convenient for families and indeed arranging services upon discharge.
Chair, can I just, before he goes?
Yes, please do, Derek.
Yeah, David, you would think that under the conditions that we live at the present moment, the lockdowns, the face masks, the social distancing, that the winter pressures are not going to be nearly as high as they are in a normal year. And that must be contributing towards making you being able to deal with the really serious issues.
You would hope so, Derek, although as I say, if we look overall at the trends at the moment, the ambulance conveyances are still slightly down. Certainly walk-ins are significantly down, particularly at PRH. What we are seeing, though, is that the patients that are coming in do appear to be sicker and therefore are putting more strain on the hospital services currently, and that's particularly true at RSH. And as I say, I know last week there were cases in the West Midlands where at times ambulances were waiting some hours to offload patients into an A&E department. We weren't talking about minutes, and surrounding hospitals, it wasn't one of ours, by the way, surrounding hospitals were equally busy and couldn't take diverts. There does appear to be, I think because patients have waited, patients are sicker when they are calling ambulances because people have been cautious about going to hospital. Yeah,
thank you.
So thank you, David. If I can just bring this to us as sort of a summary and close it up. Going back to the last item, the mental health one, I think we did mention that we'd like some sort of form of tracking of the co-production of commissioning going forward. And you said that you could bring that forward. You could come back again in 6 months to give us an update on that. And then there was also another, as we said, takeaways that you need to come back to us with. Equally on this one, as I say, is going to be there at the forefront of people's minds working our way through the winter. So if you could be minded to come back again to give another update, that would be extremely helpful.
Happy to, Karen.
Thank you. So if there's no more questions on this item on A&E, couple of seconds to allow you to come forward. No, so thank you very much, David. That's it. You're now free to go.
Thank you very much. Thanks, everyone. Bye-bye.
Thank you. We've now got co-chairs update. That's item 6. Well, really, I think we've covered everything that we wanted to cover in the last two meetings. As we go forward with the work plan, as I mentioned earlier, this is. I don't know that we've quite got to the bottom of children's mental health, and I think there's probably another piece of work that's going to come out later next year to follow this up. But it's probably going to be later in the next administration for Shropshire anyway. I also think I said that the next part of the piece of work that we'll be looking at is transition into adult services, and I do hope that we can also rely upon the people that have attended today as expert witnesses or contributors from other areas, i.e. children's services and adult social care, if they would continue to support and contribute something. Heather, I've got you down as wanting to ask something. Was that of David? I hope not.
No, it was at you.
Okay.
You went through wanting to share notes and so on so that we're on the same track. Do we have any recommendations out of today so that it's there hard and fast where we're going?
Well, that's what I want to collate later. I mean, I've made some notes. I'm presuming as well that Amanda and Daniel and Joseph will have made notes, and I want to sense check those again with David Evans about the ones that he's taken. And we can certainly circulate those to all members and publicly.
Absolutely, but we just need to have something really formal there because I mean, Zara raised lots of points and the commissioning stuff is vital.
Absolutely.
She did it all perfectly, but it does just need to be there very, very solidly when it comes to the minutes of this meeting coming out.
Yeah, we will. But of course, we need to collate them and then sense check them with David Evans that he's quite clear that this is what he's been asked to bring back, if that's okay.
But I think we've also said that we will meet with the Zara and the groups, and also some teachers to headmasters to actually try and find out exactly, you know, what they say and what they do is entirely different, and that came very clearly through again today. So there's that opportunity, but it won't be in a workshop. It'll be in a sort of an informal meeting.
Yeah, it wasn't clear to me who was going to arrange that, so it's all those sort of housekeeping details that we need to clarify.
We can fix it.
Hilary, I've got you wanting to speak, or stop eel. Hilary, there?
Yeah, that's it. I think I was having difficulty unmuting.
Okay.
Yeah, sorry for the spelling. I just wanted to ask you and Derek, I have sent you an email about COVID, and I wondered what, if anything, was happening about that, whether I should circulate it to everybody.
I haven't seen it. Derek, can you answer?
Well, it was a follow-on from the one I sent you the other day.
The weeping nurse.
With a list of questions, which I think we badly need answering by the hospital trust, and I do think this is very urgent in view of the number of people who are currently in hospital with COVID, and or who may not be if that particular regime is still being practiced.
Joseph, did you see that?
Joseph replied to me.
Did he? So therefore we've received it then.
You have received it, yes.
Yeah.
But Joseph, I mean, obviously can't say how.
No.
What if anything you're going to do about it?
Look, we are going to meet again very shortly, Karen and myself, and we'll discuss how we do it. If you'd like to, if you want to send it around to all members, then you're more than welcome to.
Yes, please do.
Okay.
You know, there's not a problem with that at all. Then we can see, you know, try and find the sense of the thing. At the present moment, there's been a hell of a lot going on about this. So
yes, I realise.
There's also a lot of other stuff going in the background up here.
I'm sure there is, but I just think this is quite urgent.
Yeah.
Okay.
Hilary, we will come back to you as soon as possible.
Thank you.
Okay, thank you for that, Hilary. So I'm seeing that there's no more people wishing to speak. Can I now ask that this meeting closes?
Yep.
And thank you for all those who have attended and observing, listening in, and we welcome any comments that you might like to make via email.
Okay,
thank you very much.
Bye-bye.
Everybody.